Thank you, Patrick. Good morning. So I'm Marc Bourlien, and I'm pleased to co-chair this session with Massimo Levrero from Italy and France. And so the first talk will be given by Graham Foster from London, and it's still a role for personalized treatments. Graham, the floor is yours.
Thank you very much indeed. And the hepatology year always begins in Paris, and it's always a pleasure to be here. And my thanks to Patrick and the team for all that they've done, bringing us all together. Hopefully, we'll get some slides. The right slides would be helpful. We can talk without slides if you prefer. How are we doing, guys? I think the yellow jackets have gone into the system at the back. Thank you. So my brief is wonderful.
This one?
Yeah, a man with ability. Thank you very much. You need young people for computers. So my role is to think about personalized medicine in the era of the new direct-acting antiviral agents for hepatitis C. And these are my disclosures, and these are the bad old days. Many of you will remember starting your patients on treatment. You genotyped, subgenotyped, IL-28, you measured the viral load, you measured the decline, then you introduced different drugs, changed the duration, and not surprisingly, very few patients completed the course. The new era, of course, is just take the tablets. And that is a transformation that opens the door to the wonderful elimination that Patrick spoke about a moment ago. But is it that easy? Do we really get to a position where you hand over the tablets and the patient gets cured? And I'm going to argue today, actually, it's not quite as easy as it sounds. And I'm going to talk a little bit about how we should, I believe, be personalizing and optimizing the use of these new treatments. So we'll talk a little bit about the benefits of pre-treatment assessment. And then we'll go on and we'll talk about the benefits of scrapping assessment and just getting on with it. So what are the advantages of assessing your patient in detail before you start the treatment? Well, the first point to make is that you need to know. You do need to know if your patient is decompensated. Because if your patient is decompensated, the protease inhibitors are absolutely contraindicated. And the chance of a response is greatly reduced. Many studies have shown that the decompensated cirrhotics respond a little less well. It seems a bit odd to talk about less good being 80–85% cure, but nowadays we expect 95%. So you do need to know if your patient is yellow and acidic. It's not hard. But this is data from the German group. The real-world study with the paritaprevir regimen, so this is a protease inhibitor, and in this real-world study, some patients ran into trouble and decompensated. And when they looked at the data, the patients who ran into trouble were those with a past history of decompensation. So the patient who drank heavily in the past, decompensated, stopped drinking, recompensated, they're the guys who run into trouble. So before you start to treat your patient, you need to look at them. Are they yellow? Are they acidic? And you need to ask the question whether or not they have previously decompensated. Because if they have previous histories of decompensation, the protease inhibitors must not be used. So you do need a little bit of pre-treatment assessment before you start your therapies. And we know that cirrhotic patients have a slightly different treatment regimen. You need perhaps to add in ribavirin with some regimens. If you're going to use glecaprevir, pibrentasvir, you need 12 weeks, not 8 weeks. You need to know if your patient has cirrhosis. And if the patient has cirrhosis, you want to keep them on long-term follow-up. You want to scan them for cancer because the cancer risk is reduced but not abolished. So you do need a little bit of pre-treatment assessment. And here's the data from the Astral study looking at soft velpatasvir in patients with genotype 3 and cirrhosis. And the response rates are just down a little. They're not horrid. 90% is a fabulous cure rate, but it's not 100%. And indeed, these data led the EASL guidelines to recommend Sofvel-Vox first line for G3 cirrhotic patients. But to do that, you need to know both the genotype and the extent of cirrhosis. So a little bit of pre-treatment assessment might optimize therapy. And of course, renal impairment is a concern with sofosbuvir. I think many of us are now getting quite confident using sofosbuvir in renal impairment. I think the original concerns have been allayed, but there is still a little moment of doubt, and I think most of us would prefer to avoid it if we could. So perhaps you do need a blood pressure and a creatinine before you start therapy. So I think whatever you do with your patient, you need some degree of personalization. You do need to exclude decompensation. You do need to think about cirrhosis, and you need to assess renal function. And then, of course, you may want to think about anticore positivity for hepatitis B. You may want to think about HIV. There are other things that you might want to consider. So what about genotype? Do we still need to genotype patients? We've got fabulous pan-genotypic drugs. Is it worth genotyping? The biggest delay in treating patients is very often the genotype. You can put a hand on the belly, assess ascites, you can get a creatinine within a few hours in most labs, but a genotype can take weeks, and it can't be point of care. So many people are dropping the genotype and moving to the pan-genotypics. And this is the sort of data that persuades you that pan-genotypics are the way forward. Here's the clinical trial with glecaprevir, pribrentasvir, 8 weeks, fantastic response rates. But this trial was only 85% in people with very mild fibrosis. Are we going to see these same results in real-world studies with F3 patients? Here again, Sofvel, fantastic results. Right across the board, 99%. Look at the genotype 1 response rates. Why wouldn't you use this? This is 1 tablet, not the 3 you need with GP, but this is 12 weeks rather than 8 weeks. Now, of course, Mr. Chairman, you and I are quite capable of taking I'm quite capable of taking 1 tablet for 12 weeks or 3 tablets for 8, but the sort of chaotic patients where we're thinking about how hard it is to get them onto treatment, is the chaotic drug user going to manage 3 tablets for 8 weeks? Is 12 weeks too long for the guy who's in prison for 6 weeks? So in the patients where we don't have time for the pre-treatment workup, they're the patients where we probably need it the most. So you want 1 tablet for 8 weeks. That's a great option. Here's the Sofvel-Vox regimen, but it doesn't work quite so well for genotype 1A. You lose a little bit of response. So if you want to use the pan-genotypic tablets for genotype 1 patients, you lose a little. You might have to give a few more tablets. You might have to give treatment a little longer. You might perhaps have to accept that the SVR rate is slightly reduced. Whereas if you do your genotyping, you can use 1 tablet once a day, 8 weeks, ribavirin-free, with real-world data showing fantastic response rates, even in the advanced fibrotics. And if you have cirrhosis and genotype 1B, the outstanding player has always been crisaprevir-elbasvir, and there's good reason why this is the case, of course, because crisaprevir is liver metabolized, it probably accumulates a bit in cirrhosis, and you see across the board with this regimen, there's a slightly better response in cirrhosis. Not, of course, decompensated cirrhosis where it's contraindicated. But if you had genotype 1B, 1 tablet, no riba, 12 weeks, 100% cure, that's what I'd take. Of course, for genotype 1A, it has a few more problems. So the pan-genotypics for genotype 1 are not quite as good as the tailored regimens. Now, it's only a few percentage points, but there's no question that you can get that little bit better response if you tailor the therapy. So those are the advantages of a good pre-treatment assessment, a full evaluation, a full genotyping. Those are the advantages you can gain, but of course that comes at a cost. And if you avoid the pre-treatment assessment, you can take your patients, give them a point-of-care test, the Cefiad machine and many others coming through that gives you an RNA result within 90 minutes. You can go in, have a test, get a cup of coffee, come back, take your pan-genotypics, you're done. How easy is that? And that, of course, allows us to get into the patients that are really tough to find. It allows us to go around the homeless shelters. It allows us to go into the needle exchanges. It allows us to do things in places where a pre-treatment evaluation is not possible. And many, myself included, would argue that that's essential for an elimination campaign. You have to have some access to instant therapies in some patients. Here's an example of an instant access program. This is Ashley Brown's work in West London. I'm very grateful to him for showing it. This is Wormwood Scrubs, a huge prison, a very high throughput prison where prisoners go in and out within weeks. And you can see on this slide that what he's achieved with a point-of-care Cefiad test and a FibroScan and then treatment. So the prisoners are assessed once, they get a FibroScan, a point-of-care test, and within 24 hours, they're on a pan-genotypic regimen. And you can see he's achieved 70% sustained response. 30% of the patients disappeared. Did they take their treatment? Did they finish the course? I've no idea. But here's a population where I'm getting 70% SVR, and perhaps if I had to wait for a genotype, I'd get 0%. Is 70% good enough? Well, maybe. And of course, there are concerns. This is data from the veterans, that some of the very short treatment regimens might be suspect in the more chaotic patient populations. So the Veterans Administration has now treated nearly 160,000 patients. All the easy patients have been cured, and they're now moving into the homeless shelters, moving into the drug users, moving into the very chaotic people with lifestyles that make it difficult to comply with treatment. And here in these data that were presented at AASLD, you can see that for the genotype 3 patients taking GP, there was quite a significant fall-off in SVR in the 8-week regimen. You can correct that by using 12 weeks. You can see for genotype 1, there wasn't a problem. So again, there's just a hint that in the patients where you have to use treatment that's pan-genotypic to get them on treatment, the response rate is going to drift down because you can't optimize. So I believe, Mr. Chairman, that if you can assess your patient, you will increase the response to treatment. And I think the more assessment you do, the better the SVR. And you can move from a 90% to a 98% by really evaluating the patient and optimizing the treatment. But that, of course, only applies to the compliant patients who will complete the evaluation. Because for the chaotic, poorly compliant patient, every step you introduce reduces their chance of starting therapy, and by the time you've done a genotype, an ultrasound, a FibroScan, a full blood count, they've gone, and the SVR rate is 0. So I believe that good medicine is always personal. There are circumstances where the individual patient is perhaps better started on treatment immediately, and that's a judgment call. Because I do believe that the more you assess the patient, the better the response. But the more you assess, the less patients you can treat. And I think the question is which patient will tolerate a careful workup, and in which patient is it better to go straight on to treatment. And that's never a simple decision, but it's a decision that we should be making and an evaluation that we should be undergoing. I do believe that to eliminate hepatitis C, we will need easy access to pan-genotypics, but in my practice, I think that will be a minority of patients because I think you can get fast throughput genotyping. I think you can evaluate patients very quickly, and there's no reason why a patient can't be started on treatment 2 or 3 days after their first attendance. So I think, Mr. Chairman, we should take great care that we don't make perfection the enemy of the good, and every patient should be assessed and started on the treatment that's best for them. Thank you.
Thank you, Graham. So we are going to make global discussions by the hand of the sessions.
And it is now my pleasure to introduce the next speaker, who is my co-chairman, Professor Marc Bellier. He will present a talk on Is DA treatment failure still an issue?
Thank you, Massimo. So I'm not going to give the presentations of Graham. Already done. So is DA treatment failure still an issue? And I think that the simple response to that is not really, and I'm going to try to demonstrate that during the next 15 minutes. So SVR is not anymore the challenge, and I think that Graham have shown you that, and failure is rare in the real practice now with the current regimens available. However, despite that, a lot of patients have been treated since 2014, and in Europe, in the US, we can expect to have still 47,000 patients will be DA failure by 2020. And most of them, since 2015, will be NS5A failure. So of course, when we have to deal with a failure to DA, we have to take into account a lot of things. First, treatment regimens, and clearly the resistance and the failure differ according to the specific DA regimens that have been given. Of course, it's also a matter of durations of treatments, adherence of treatments, and the use of not ribavirin. Cirrhosis is also an important thing to take into account, and it's quite clear that in some studies, it's appeared that cirrhotic people are maybe more suitable in a short number of time of failure. The third thing is resistance-associated substitutions, and clearly these resistance-associated substitutions, the RAS, are clearly different according to the class of drug that have been used, and clearly when you are using a protease inhibitor, an NS5A inhibitor, or a non-nucleotide NS5B inhibitors, there is more risk of getting any resistance-associated substitutions. Moreover, we know that the barrier to resistance is lower for protease inhibitor and NS5A. And if you are looking to the subtype, genotype 1A patients are more suitable to develop resistance compared to genotype 1B patients. However, most patients with failure with the current DA regimens had emergence RAS after the failure. And moreover, 15% of patients had baseline NS5A RAS with variable effect on G1A response. And clearly one of the most important problems is that NS5A RAS persists much longer than the other RAS induced by either protease inhibitors or NS5B inhibitors. So if you look at the clinical guideline given in 2016 by the EASLs, the recommendations was, first, the discussions was, is there an interest to do any kind of HIV resistance testing prior retreatment in a patients who fail on any DA-containing treatment regimens? And the answer was, well, we don't know. If reliable resistance testing could be performed, retreatment can be guided by the probability of response according to the resistance. So clearly there were simple rules that have been given. If a patient fails regimens containing SOF plus a protease inhibitor, it should be retreated with the combinations of SOF plus an NS5A inhibitor. So that's the simple things. For the patients who are infected with genotype 2, 3, 5, and 6, who fail regimens containing NS5A inhibitors, at that time, the only option was that the patients could be retreated with SOF-VEL plus RIBA for 24 weeks. And for the patients infected for genotype 1 or 4 who fail regimens containing an NS5A inhibitors, there were several options at that time that have been proposed. Either a combination of SOF plus the 3D from AbbVie plus RIBA, either a combination of SOF plus Zepatir plus RIBA, So, or either a combination of sof-sim-dac plus RIBA, but these last combinations give very conflicted results in the literature, and especially in some patients, the one with the most advanced disease, it was a little bit tricky with some very hard side effects. So that was not a real recommendations. And globally, the durations of treatment should be of 12 weeks for genotype 1b or 4 patients with a low fibrosis score, and it should be 24 weeks plus RIBA for all patients with genotype 1a and for patients with genotype 1b and 4 with advanced fibrosis score or compensated cirrhosis. Now everything has changed in 2018 with the issue of two new regimens. The first is the triple regimen, sof-vel-vox, and this regimen is really recommended either by the ASLD regimens or the EASL recommendations, and the other options recommended by the EASL guidelines is the combinations of sof plus glecaprevir pibratesvir for 12 weeks. So this is the recommendations from the EASL. As you can see on this slide, the recommendations from the ASLD are a little bit different. They almost recommend a sof-vel-vox in all the cases, but you can take into account that for genotype 1, for example, they also recommend to use sof-vel in genotype 1b or glipib in genotype 1a or 1b who are failure to non-NS5A regimens. And for those who fail an NS5A regimens, they have recommendations to propose glipib for 16 weeks in these populations. So that was based on the following studies. The first study is the Magellan study. The Magellan study regards the retreatments of DA failure with a 12 or 16-week GP regimens in genotype 1 and genotype 4 patients. The overall SVR rate was between 89 for 12 weeks, 91 for 16 weeks. But when you look at the SVR according to the previous DA regimens or to the RAS, you can see that patients who had NS3 RASs respond very well either to 12 weeks or 16 weeks. But as soon as you have an NS5A RAS, the SVR rate is much more lower. And when you have NS3 and NS5A RAS, the results are really not optimal. The second studies that have been based for the recommendations is the latest study published by Mark Sutkowski and presented at the AASLD. In these phase 3 studies, people were treated. It was genotype 1 people who failed an NS5A inhibitors, and those populations were retreated with GP for 12 weeks or GP for 16 weeks in non-cirrhotic patients, and in cirrhotic patients, they were treated with GP plus RIBA for 12 weeks or GP for 16 weeks. And you can see on this slide, these regimens can work only in genotype 1b patients, because in genotype 1b patients, the result is optimal. But in genotype 1a patients, you can see that the results are really suboptimal with a high rate of relapse in these populations. So now we move to the sof-vel-vox regimens. And that's the Polaris 1 and 4 study that have been published years ago. And this is the largest study done on DA failure. And the study was divided between the Polaris 1 study, in which patients who were failure to NS5A inhibitors were retreated with sof-vel-vox for 12 weeks. And the Polaris 4 study is concerned the patients who fail any DA regimens without NS5A inhibitors. And clearly, the SVR rate among the two studies globally was 97%, and there were only 6 relapse in NS5A inhibitors failure, and 1 relapse in the Polaris 4 study. From the Polaris 4 study, the recommendations of ASLD that you have seen for genotype 1b come from this data. And as you can see on this slide, for genotype 1b patients, they could be retreated either with sof-vel or sof-vel-vox for 12 weeks, and they achieved the same SVR of 95%. For the rest, for the other regimens, clearly there is an advantage to be retreated with sof-vel-vox compared to sof-vel. If we look now to the patients who fail the regimens with NS5A inhibitors, clearly the SVR rate was across the board the same, whatever genotype and whatever also fibrosis stage. However, the 6 patients who relapsed in Polaris-1 study were all cirrhotic patients. Now, if we look at the impact of RAS, because most of these populations harbor RAS at the beginning of treatments, clearly there is no impact of the RAS on the high efficacy of soft-Velvox, whether in Polaris-1 or in Polaris-4 study or in the combined study analysis. And as you can see on this slide, the SVR rate is 98% if you have no RAS and 98% if you have any RAS, either NS5A, NS3, or the combinations of both. If you look at the SVR according to genotype and baseline RAS, again, there is no clear difference, even if genotype 3 harbor a slightly less good response of 94%. If we look at the SVR rate according to the number of baseline RAS, again, there was no difference. Either you harbor 1 or 2, 3, or 4 RAS. And if you look, for example, for the NS5A RAS among the different positions, there is also no difference according to the positions of the mutations. So clearly, these studies nicely shown that there is no impact of RAS on the high efficacy of soft-Velvox. Is there any issue with the emergence of new RASes in these patients who fail soft-Velvox? And I put here on this slide all the result of the 12 patients who fell either in Polaris-1, 4, or in the DEFER Polaris-1 studies. And clearly there was only 3 patients who developed new RASes after the failure on soft-Velvox. The first patient is a patient who had suboptimal regimens because he stopped treatments after 3 weeks of treatments. So that's why he had a breakthrough. There was no breakthrough either for all the other cases. Is that data confirmed in the real life? And the answer is yes. The soft-Velvox failure, soft-Velvox treatments in DA failure display very comparable results in real-life data, either in the US, either in the Spanish, and the lowest result came from Spain, and in the Spanish experience, the lower response was observed in genotype 3 patients. More interestingly, there was an issue that had been raised on the last SLD meeting, whether patients who fail soft-Velv can be treated with soft-Velvox. And this issue came from the data of the veterans cohort, in which in this large database, it's appeared that people who were failure to soft-Velv respond less well to soft-Velvox compared to the other regimens. Is that really true? Because the number of patients is really small. When we go back and we look among the Polaris 1 and 4 study, among the 40 patients who were previously treated with soft-Velv and then retreated with soft-Velvox, you can see that the SVR rate is 95%. And again, there was no, most of the patients responded, and the only 2 patients who relapsed were genotype 3 patients. And if you look at the trio cohort result in the US, 95% of the soft-Velv failure achieve SVR on soft-Velvox, and in the German cohort is 100%. So clearly, it's appeared that it's not really an issue. Moreover, we have no clear data on whether patients who fail on GP can respond to soft-Velvox. And now we have this data coming from the US experience. It's a small cohort of 14 patients, but 13 among the 14 patients achieve SVR, and there was only 1 genotype 3 woman without cirrhosis who had a relapse. So clearly, this is an option that can be taken. The other option is to consider soft plus GP in GP failure, and that's the Magellan 3 study. And clearly here, again, the response is very good with 96% SVR, and the only patients who relapsed was a genotype 1A patients with compensated cirrhosis. So clearly, soft GP plus RIBA for 16 weeks is an option for at least all the patients, and for the genotype 3 patients, as whole, the genotype 3 patients responds to this treatment. This was confirmed also in the real-life data coming from the French ATU, and as you can see, all patients retreated with soft GP achieve SVR so far. So, in conclusions, we have options for any DLFR in 2019. By using either soft Velvox or soft GP, we are, and in some cases, GP or soft-vel alone, we can achieve SVR in almost all patients. And I think that if we need to have an approach for any DA failure, we first need to consider a reinfection as a cause of recurrent viremia. We need to assess adherence persistence to prior regimens. We need to reassess genotype in order to differentiate new contaminations to reinfections. We need to assess liver disease stages. And there is two different situations. If you have no cirrhosis and a single DA failure, you can either retreat your patient with at least 2 DA predicted to be active based on a prior DA use, or directly you can use the triple regimens for 12 weeks, soft Velvox or soft GP. And in this case, RAS testing is not recommended because it didn't have anything and it will not inform you. In case of patients with cirrhosis or prior therapy with both NS5A or NS3 protease inhibitors, RAS testing may be recommended, and at least RAS testing might be interesting to get the informations. But it's not really useful so far. And in these situations, you should consider a triple regimen with soft Velvox and soft GP. And the last situation is when you have these very difficult patients with compensated cirrhosis who have been treated with several regimens. In some situations, you can consider to add ribavirin, and that is the recommendations for the genotype 3 cirrhotic patients in the US guideline, or extend the durations of treatments either to 16 or 12 and 24 weeks as recommended by the EASL guideline. Thank you for your attention.
Before introducing the next speaker, I want to remind everybody, you should have been already informed about that in preparation for the general discussion of all the presentations, you should have received something like that. And if you have an iPhone, it is just enough to capture the little design, and the application to make the question will be on your iPhone. If you are with an Android or other kind of phones, you should have already installed the application that makes your telephone capable of capturing this little design. And that's it, and I give.
Thank you. So if you need any iPhone, Patrick will provide you downstairs, freely, of course. So we are going to move to the next presentations, which is given by Stanislas Paul. So are still difficulty to treat patients, or difficult to treat patients?
Merci. C'est ça, oui.
Oui, je sais.
Sorry. Hello. We are going to show you the QR code that you can flash in order to ask your question to the chair. Do not hesitate to take your iPhone now or Android. It's just simple. You put your photo. Are you ready? Sure. And then you have the QR code. Tu peux l'afficher en entier? La régie, est-ce que vous pouvez l'afficher en entier, s'il vous plaît, la slide? En plus gros, le QR code. Then you can flash the QR code and it goes in a system. Then you can ask your question to the chairs. We will put this slide again later, and during this day, today and tomorrow, you will be able to ask your question. Do not hesitate. Thank you.
Okay, dear Marc, dear Massimo, Dear Patrick, thank you for the invitation. I will discuss if there is still difficulties in treating patients. So these are my disclosures. Last year, I claimed that pangenotypic DAs removed the so-called special population since we achieve SVR in most of the patients. But it's true that it does not completely remove the difficult-to-treat populations. We know that in the previous special population, including HIV co-infected patients, there was a lower SVR rate, but now, with the new pangenotypic treatment, whatever your choice of valve for 12 weeks or the combination of GP for 12 weeks, it's possible to achieve very high SVR rate. And we just heard with Mark that it's exactly the same with the DA failure patients. And so all those prior difficult-to-treat patients disappeared. And now the new trend, as you know, is a reduction of the duration of the treatment, and probably the new standard will become, at least in easy-to-treat patients, who represent the majority of the patients we are now facing, naive, non-cirrhotic patients, will be the 8 weeks duration. And this is true whatever the therapeutic choice and whatever the genotype. You can see there that the 8 weeks treatment for genotype 1b or genotype 4 with the grazoprevir-elbazir combination results in a high rate of SVR. It's the same for genotype 3, who were given the Sofvel, which is, as you well know, usually given for 12 weeks. And finally, in rare genotypes like genotype 5 or 6, the GP for 8 weeks in non-cirrhotic and 12 weeks in cirrhotic results in very high SVR rate. So clearly, most of the situations are easy. But there are still two populations which are difficult to treat. And after the discussion of this population, short discussion, I will discuss the difficulties in the daily practice. The first population is that of decompensated cirrhosis, and it is detailed just after this session by the Professor Schiffman, so I will not go into the detail. And Graham, of course, already emphasized that there is a lower SVR rate in the decompensated cirrhosis, child B or C, as compared to the compensated cirrhosis. And we heard that there is a major contraindication for the use of protease inhibitors. You know that it has been proven previously in HIV infection. The second point is cirrhotic patients with hepatocellular carcinoma, and hepatocellular carcinoma per se reduce the rate of SVR. So really this is the main remaining difficult to treat population, but as you know, and given the early treatment, the improvement in the screening of patients, clearly this population is markedly decreasing. The other population is the population of patients with cancer. Of course, we are not discussing of hepatocellular carcinoma, but any cancer. And there is in these patients some discussion around the benefits associated with the treatment of underlying HCV infection. And clearly there is some risk of HCV reactivation, and also like for HBV, a risk of immune restoration syndrome, which may result after restoration of immunity in the death, in liver-related death in those patients. And so clearly we have to argue the interest of achieving SVR before the chemotherapy, and the short duration probably is important to consider in order to avoid a reduction of the safety and the efficacy of the treatment. And the safety issue, of course, is another concern, because you know that in our daily practice, underlying liver disease may increase the toxicity of any drug. We don't know if it's so true for checkpoint inhibitors, but for most of the antitumoral drugs, there is high risk of hepatotoxicity and, of course, of limited efficacy of this treatment. So, two remaining difficulties in the practice. If we consider the elimination plan, which will be probably achieved in a lot of countries, we have to remember the importance of screening, access to care, and the follow-up of cured patients. But we will discuss these topics within the next hours. And so I would like to mainly discuss the three main limitations in the practice of the treatment of our patients, the daily practice. They are drug-drug interaction, the adherence, and the safety of the drugs. So if we consider drug-drug interaction, you know that usually it is easy to manage, and thanks to different tools, including these electronic tools, it's very easy to observe if a given drug is contraindicated or not recommended. And so in this situation, usually we can adjust the treatment to the co-medication. The example is the statin, but we can also make an adjustment of the DAs according to the co-medication, and considering that in this situation we have to keep a given medication, we will make another choice of antiviral treatment. But sometimes these drug-drug interactions are almost impossible. This is a true example, patients treated for seizures, and if you consider the risk of DDI, clearly it's difficult to treat those patients. And in this example, if you analyze in detail the metabolism, the transformer of each drug, and the interaction with the anti-commercial drugs, it appears that the interaction with ledipasvir, for example, and sofosbuvir is weak. And so in this difficult situation, you can consider to use this combination. But you need to consider a drug monitoring and to evaluate the C-mean and the concentration of the sofosbuvir metabolite during the treatment, so at least at the beginning of the treatment at D7 and during the follow-up in order to adjust and to avoid toxicity of the drug or inefficacy of the antivirals. And another point is that in some situation you can consider a dose adjustment of your drug. And of course, the single tablet regimen is not an help in this situation. Remember the daclatazir, which could be used instead of the classical 60 milligram per day at either shorter dose, 30 or higher doses at 90 milligram according to the use of a given antiretroviral treatment. So it's mainly manageable, but it may be sometimes difficult. Another point regarding drug-drug interaction is the risk of automedication. This is a French study evidencing that usually almost half of the patients are taking automedication. You have there the list of this automedication. You see that it's not very risky, but it exists. And we have some example of automedication which may decrease the absorption of the antivirals, for example, the nukes. And so we have to be aware and cautious. And this is particularly true also for the drugs like cocaine, methamphetamine, or the chemsex. As you know, there is an over-consumption of these drugs, especially during the weekend, and a risk, of course, of an interference with the absorption or non-adherence to the antiviral and antiretroviral drugs. The second limitation is the non-adherence to the treatment. And in this study, analyzing the adherence to sofosbuvir and ledipasvir, non-adherence being defined as non-intake of at least 7 pills of the sofosbuvir-ledipasvir combination, it is noteworthy that non-adherence was the major cause of treatment failure. So, of course, and particularly at the time where we are discussing to open the prescription to any physician, we have to remember the importance of this non-adherence. Non-adherence is mainly related to the incapacity to take the drugs as prescribed, but it is noteworthy in this US study that the number of visits was lower in non-adherent patients than in adherent patients. And so probably again at that time we are discussing very easy treatment, very rapid treatment. We have to consider, at least in the so-called chaotic patients by Graham, that we have to increase the number of visits and not to decrease in those patients. Finally, the third limitation is tolerance of the drugs. As you know, most of the pangenotypic combinations are very safe. And this is some results of the French Hepataire cohort comparing DA-treated patients as non-treated patients. So you see that it's around 10,000 person-years as compared to 40,000. So we have the big data interest by Patrick. And if you consider this big data, there is no major signal regarding the occurrence of severe adverse events, including bradyarrhythmia, pulmonary hypertension, death, or tumors, including hepatocellular carcinoma. So, of course, the main message is these drugs are safe. But remember that we reported some years ago bradyarrhythmia associated with DAs, and in those patients who had implementation of the pacemaker related to atrioventricular block resulting in syncope, it was possible to demonstrate that there was bradyarrhythmia during the exposure to the sofosbuvir and a complete spontaneous resolution of the atrioventricular block after treatment discontinuation. So, of course, these events are very rare, around 1% or less than 1%, but they may occur. And the point is not to consider that there is a contraindication to a given treatment, but there is a need for awareness and the information of the patients and the physician, and probably to limit or avoid the use of a given drug according to the baseline situation, in this situation, of course, pre-existing cardiac disease. Regarding the hepatocellular carcinoma, I will not go into the detail because there is a presentation in the next session. Just to remember you that there is no major signal regarding the recurrence of hepatocellular carcinoma. This is again the French cohort, so it's really reassuring. And I would like, even if it's discussed later, to mention the risk of occurrence of hepatocellular carcinoma, because it's, of course, a matter of debate, and it's mainly a methodological issue. In our French cohort, we have compared those patients who have been treated by DAs to those patients without treatment. So it's a prospective study comparing treated and untreated patients. And of course, you can see that there is a higher rate of death, hepatocellular carcinoma, and cirrhosis decompensation in the treated patients as compared to untreated patients. And of course, if you make a crude comparison, you can suggest that there is almost a threefold increase of occurrence of hepatocellular carcinoma. But this is related to the prioritization of the treatment in our country. And as soon as you introduce a weighting by IPTY methodology or a Cox model, you can evidence that the homogenization of the heterogeneities of the patients, treated and untreated, demonstrate that there is a benefit associated with the treatment. This is true in the general population, including patients with mild liver disease, and this is, of course, true in the cirrhotic population. So regarding the safety, we don't have any concern regarding the benefit of the treatment, and this is also true with the same results regarding the all-cause mortality. This paper will be published very soon, but you can observe that SVR is associated with an improvement in the complete population as compared to the absence of treatment. So in conclusion, ladies and gentlemen, we have high and pangenotypic efficacy of the different regimens, which remove the special population, but there is still some difficult to treat population, and three main remaining difficulties in our daily practice, but most of them are manageable or preventable. They are the drug-drug interaction, including phytotherapies and other, of course, automedication and drugs. This is adherence to the treatment, and probably despite the shorter duration of the treatment, we have to maintain therapeutic education. And finally, the third is safety of DAs, which is mainly very fair, but which does not exclude rare and potentially severe adverse events, which need information and cautious prescription. Thank you very much for your attention, and I thank my collaborators.
Thank you, Stan. So the session is open to discussions. So we have only one message questions. I think that the system could not very work, and I put it on the screen. So Graham, well, it's...
We may not put it on the screen.
From the mouse? Okay. Okay.
Don't go away.
So Graham, in your speech, they don't get the point around pill burden. Why would it be an issue?
I think pill burden, it's an interesting question. I think there are 2 points to think about with pill burden. The first is there's plenty of old data looking at compliance based on number of medications, and the compliance doesn't start to fall off until you get beyond 2 or 3 pills a day. So you can probably take 3 pills a day without too much impairment of your efficacy. The difficulty comes that most of the patients we're talking about are already on multiple medications. They're taking their methadone, their buprenorphine, they're taking their antidepressant, they're taking their antipsychotic, and then you're adding on another 3 pills, another 1 pill. And that, I think, is where it starts to get difficult. I think the data that we have is the compelling data from the US veteran study, where the 8 weeks of the triple GP regimen was slightly less effective in that population than it was in the clinical trial population. So I think we have to see more studies. I think we have to see a lot more real-world studies before we can draw conclusions. But that's the first hint that perhaps there might be a problem with these super short regimens. I think there is a real question as to whether or not we dare shorten the regimens in the very chaotic population where they start to miss medication doses. And I think the more tablets you add to that regimen, the more complex you make it, the more likely you are to have missed doses. So for me, I think a slightly longer treatment duration, I think a slightly simpler duration is clearly going to be that little bit easier. And we're fighting for very small margins here. I don't think we'll ever see a randomized controlled trial because the size that we'd need to compare 12 to 8 weeks in a chaotic population, 1 tablet to 3 tablet, is never going to happen. But common sense says the more complicated you make these regimens, the more likely you are to have failure and the more likely you are to miss doses.
Thanks, Graham. Next questions. Do you wait 6 months for treatment initiations in order to differentiate chronic versus acute, or it's done?
Do you want the official or the unofficial version?
Well, the unofficial.
If you've got a guy who's hepatitis C RNA positive, you want to get them on treatment straight away. And I think that in that setting where acute infection is likely, you're not going to do a great deal of harm by starting them while you've got them engaged. I think you lose far too many patients by finessing and trying to insist on 6 months. Do you Europeans, now that we're separated, do you wait 6 months?
No.
Europeans never play by the rules.
Exactly, especially the French. But I don't think that I think that the German is doing exactly the same, so that's fine. Next question is, what is the best approach for decompensated cirrhotic patients failing a SOF plus NS5A plus RIBA? In these situations, there is no clear recommendations. I think the best the recommendation is to transplant these patients and to try treatments after transplantations. The current recommendations in these situations of decompensated cirrhotic patients is to go for SOF-VEL plus RIBA for longer durations. But nevertheless, we have no experience for those decompensated cirrhotic patients who already failed SOF NS5 inhibitor plus RIBA. And the next question is, can the panel provide clear recommendations whether to treat cancer patients co-infected with Hep C due to have chemotherapy prior to the initiations of cancer therapy?
Well, of course, it's difficult to make a recommendation. As you know, in the recommendation, usually we consider that there is no place for a treatment with a life expectancy lower than 1 year. But first, it's of course difficult to bet on the life expectancy, and second, there is major progress in the treatment of the patient. So my preference should be to consider the treatment for all the patients who are supposed to be given a treatment for their cancer, mainly because when you consider, and this is also true for hepatocellular carcinoma undergoing palliative treatment, there is an increase in the overall survival of the patients who have been treated by DAAs as compared to untreated patients. So probably results are limited. Perhaps they are not completely convincing, but my trend should be to treat probably all the patients who are considered for an anti-cancer treatment.
If I can just, we will discuss again this at the end of the next session after the plenaries. But one important point is, and the question is there, whether to treat for hepatitis C before the cancer treatment or not. And this, I think, is really to be personalized patient to patient, because it's completely different in considering what is the compensation state and what is the oncologic program for the patient. If he is a patient with not a big issue that goes, but a large tumor, but not growing very fast, that will go in a trial. The trial is closing, you go into trial, I think. It's just common sense. The trial is open for a long time. You have 8 weeks to go or 12 weeks to go. You can manage, you can try to treat. What is the real advantage to treat before starting the oncologic treatment? It really depends on the oncologic treatment, if you can elaborate on that.
Probably to decrease the risk of liver toxicity of the drugs. This is the same for the treatment of patients undergoing liver surgery for hepatocellular carcinoma. There is always a debate. Of course, it's possible to make the treatment after the surgery, but probably the post-operative period is easier. And I think in the situation of the cancer, it's the same. First, 50% of patients in phase 1 studies of new drugs with HCV are excluded. So we have few information. Second, it's true that the risk of liver-related toxicity is usually low, so it's 5 to 10%. And so I think it's very difficult to generate very strong answers. But in some of the patients, for example, in lymphoma, we know that pre-existing treatment may be beneficial, of course, for non-Hodgkin B lymphoma, but also in diffuse lymphoma, you decrease the risk of discontinuation of the treatment related to hepatotoxicity, which result in overmortality of the patients. So my feeling is that if you begin heavy treatment for the cancer, it's better to have a clean patient, perhaps before or during also, because it's true that if there is no drug-drug interaction with the chemotherapy, it's possible to make both.
Okay, so in order to keep you on time, we are going to just ask 2 short questions and short answer. So in real life, it is not necessary to test for RAS. The answer is yes. And Graham, the next question is, why ribavirin play a role in Hep C treatment?
Ribavirin should not play a role in hepatitis C treatment if you can possibly avoid it. I think in some of the very exotic retreatments, it might still have a role, but let's take it out and keep it simple. It's a dirty drug.
Okay. Any comments? No. Okay. So thank you, and I thanks the speakers.